Carl, is there any specific part that you're just kind of, it goes out at, or do you, just a generalized thing with the CPT only or ICD-9 both?
I think with the CPT, I just haven't figured out how to look for the keywords yet.
Okay. Well, then that's what we're gonna do. We're gonna go over some of these review questions like we did. Is that okay with
All the
you?
notes and slides and this that I've put all together.
Yeah.
Just getting
It's
back
a
to
study
study
guide, so
guide.
we can go back and forth.
And I think I'm just not getting, keeping out.
From what?
It's from the
Right.
slides and from the stuff that we've highlighted in the study guide.
I'm
I'm not finished. I've only done like a little bit of it, but I'm gonna go back and do ICD-9 too.
all up on the game. Yeah, that's one I really need. I still
Yeah.
have trouble with ICD-9.
I was trying to find the,
God,
I figured it's saying in the summary
me and these fast.
of the book. Introduction to ICD-9, introduction to
Not very cute,
surgery.
When did you find the time?
At work.
I
See,
could.
this is all these slides.
I can't take mine to work
Before
anymore.
the study guide. It
I
shows you
can't do mine to
the
work neither.
CPT code basics. Is that the CPT index is alphabetized with main terms organized by the condition, the name of the procedure or medical service documented, for example, a removal, suture, fasciotomy, the name of the anatomic site or organ, neck, skin, femur, synonyms, eponyms, and abbreviations, CHO/interphalangeal joint, Watson-Jones procedure, EEG. All right, so let's go to chapter review.
Can I turn the air on for just a minute? I've been riding in a hoopty with no air for a whole hour.
I so totally missed out on being able to take care of baby Kenan today.
Huh?
Michelle asked me if I'd watch Kenan and Carrington for a few hours before Gigi.
Did you?
Yeah, and I was like, oh, dang it. She finally asked me and I'm sick.
I had to go by and get them at Carrie's house and load all the. Oh my God, it's like you're moving. I forgot what it's like to have an infant. Jesus. And then putting 2 car seats in the car and buckling them in. No,
It's not.
I had to just stretch me for a reason, obviously. Woo. Carrington said, Titty, it's hot back here. I said, I know, baby. Look, Titty, roll your window down a little bit. We don't have no air in the hoopty, baby. Oh, gosh.
If it's not one thing, it's another.
I hear you. Stupid car. Probably gonna spend
Jana, I think I have this set now that it'll record without stopping every 15 minutes.
Jennifer is on the ball.
Huh?
This, I was having to stop it every 15 minutes. I think it'll record 30 now. I
Yay.
think I have it fixed.
Awesome. All right, let's look at chapter review number, page 114. This one is in the Mrs. Guy section. And, let's look at number 6 and we've been focusing in on our CPT, but on this particular example, there's a few of them. They include the ICD-9. So let's try to do it all. A 3-year-old is brought into the ER crying. He cannot bend his left arm after his older brother pulled it. The physician looks at the x-ray and makes a diagnosis of dislocated nursemaid's elbow. So I would underline dislocated nursemaid's elbow. The ER physician reduces the elbow successfully. The patient is able to move his arm again. The patient is referred to an orthopedist for follow-up. What CPT and ICD-9 codes should be used? All right, when you're looking at all that, like I said, I kind of go through things, underline and highlight them. And the diagnosis, of course, dislocated nursemaid's elbow. What did they do here? They reduced it. So I don't know if we're going to be able to find it under reduction. You should.
So,
So reduction, elbow.
reduction.
For diagnosis.
No, under the diagnosis.
Okay, if I want to go on reduction, the only thing they've got there is dislocation. If you go to nursemaid's elbow,
If you go to reduction and look under elbow, it's there too.
Yeah, it's there.
That's what I do.
Yeah.
Look under elbow.
and if you go to nursemaid elbow, it also takes you there.
Does it? Okay.
So those are the two ways that we look that one up. So 24640. Go and look at it in the fall. It's clear that it's close treatment of the radial head subluxation in the child, common nursemaid elbow with manipulation. And that's what they did.
I don't see it under elbow.
I don't see it.
It takes you to close treatment under elbow 24600, 24605, all the way to 24640.
Elbow.
Too
Elbow,
close.
right?
And if you go over here and read it,
Yeah.
starting with those, you can figure out which one it is.
It's on page 96,
So it narrows your
third column.
answer down there, your multiple choice answer. The reason why they're putting the 54 modifier on that, and that's something to keep in mind as you're going and answering your questions, especially for your test, is again, in the emergency room, a lot of orthopedic care is done, but they're not ortho docs, and they don't follow up for that care. They're at the ER every time they're referred out to ortho. So 54 is for the surgical care only. When they go to orthopedics for their fracture or their dislocation follow-up, you'll actually put, is it the 55? Modifier on the post-surgical care
Yeah.
to indicate that the global doesn't necessarily pertain. The amount of payment to that ER physician will actually be less than the normal payment, because remember, all codes have a global component. All the money that you should get paid for the pre and post-treatment of that condition is bundled into that code. So those modifiers will affect the payment greatly. But at the same time, if this child left the ER, went straight to ortho, and ortho just looked at the child, or the next day, went look at the child and did follow-up, if they would have reported the 24640
Look under
twice
reduction.
at the ER and the ortho doc, it would have been a red flag for billing. All right, so then, your ICD-9, look, I think everybody bring it. I think you could go straight to nursemaid elbow index.
Reduction, elbow closed. Takes you right there.
takes you straight to it. So basically, on those two, we were able to figure it out that A is the appropriate answer. The E927.0, that's your overexertion or strenuous movements, E code. It doesn't tell where it happened, so that's why they don't have a place in the front of it. But A is your answer on that one. Under it, number 7, well, let's see if there's more. Number 7, a 50-year-old male had surgery on his upper leg 1 day ago. He is presenting with serious drainage from the wound. He is scheduled back to the OR for an evaluation of the hematoma. That's what you underline. His wound is explored, and there is a hematoma at the base of the wound, which is very carefully evacuated and the wound irrigated with antibacterial solution. Y'all might not, I'm trying to kind of put you on the right direction here. Remember with our I and D codes of the skin, before we got to musculoskeletal system, you had certain I and Ds, just kind of like lesions. You had separate skin lesion codes, and you have separate codes for post-operative complications, and that's what this is. So, what I would go, the wound was explored, hematoma, carefully evacuated, which means it was drained. Look in your CPT book for hematoma and see where it is. If you go to hematoma in your CPT book and then to leg, upper, it directs you at 27301. Now when you're reading this, and let me just make sure I've got this right before I tell you otherwise, because I'm going to show you documents. When I was first looking at this, I was questioning myself. If you look at 27301 in the book, it shows you that it excludes the superficial incision and drainage codes. And then you have to refer back to the note. What makes this a deeper wound is it says at the base of the wound. It's not on the top layer of skin. It says the wound explored and the hematoma is at the base of the wound. That's why they're going with a 27310. If it would have stated that the hematoma was incised and drained, like a percutaneous thing, or without an incision and wound exploration, that would have directed you back to the skin section codes.
So what did you look up for that?
Hematoma.
Leg, upper.
When at the very beginning of class, I went over back back to like chapter 2 or 3 of the study guide, there's 3 or 4 different ways to look up your CPT procedures, and one of them is actually by the diagnosis. You can't always do that, though, and that's why I didn't throw that out there or even think about it when I was going over everything, is because every diagnosis is not necessarily in this book, whereas every procedure is. And a lot of error can be made based upon the diagnosis. Just be careful when you're searching your CPT book for a procedure based on the diagnosis. But if you go to hematoma in the leg, and then upper,
So that one's D.
and for the hematoma, in your ICD-9 book, you can look it up as hematoma, and I think postoperative. Let me see. Yeah. Yeah, postoperative. You get that underneath the shoes. Now, when you're taking your test, if you grab onto certain parts of the coding concept in general better than others, sometimes it might be best for you to skip to that part of that answer of the choices to see if you can start marking things out. The rationale, save you time, just like the modifier. I could have looked at this and said 76 is wrong, that's absolutely not right, and 78, 79 I need to look at, I can't remember to refresh it, but the 78 is returned to the OR during the global. But D's your answer there. Okay, number 8, a 45-year-old presents to the OR with the right index trigger finger. I'd underline that. And left shoulder bursitis, I'd underline that. The left shoulder is injected with 1 cc of xylocaine, 1 cc of celestone, and 1 cc of marcaine. Celestone is a steroid, or what else? It's kind of like Kenalog. And injections into joints are common, especially for bursitis. So that right there is what they did on the left shoulder for the left shoulder bursitis. Then an incision was made over the A1 pulley in the right distal transverse palmar crease about 1 inch in length. This is taken through skin and sub-Q tissue. The A1 pulley is identified and released in its entirety. That right there, the A1 pulley, released. That's what they did. The wound is irrigated with antibiotic saline solution and sub-Q tissue injected with marcaine with epinephrine. Skin's closed with furrow at the line suture. Clean dressing is applied. What are the codes for these procedures? I guess when you start looking at things like this, it's important to realize what is actually the procedure note and what standard protocol. They're always going to tell you that what layer the incision was made through. They're always going to tell you how it was closed, what type of suture was used. A lot of times blood loss minimal, or that patient was positioned in supine or prone position. There's certain things that you kind of just eject away after a while when you start realizing what it actually means. But again, the only thing they did on this one when they did that is shoulder injection with the steroids, less so. And then they're telling you all in this next few sentences that they made a cut over this right here, your A1 pulley. They made a cut there, about 1 inch long. Then they went down through the sub-Q tissue, so they're down to the tendon area, and they cut the A1 pulley. They released it. So first of all, again, if you look at this from a diagnosis standpoint, if you pull the trigger finger, it'll take you to the A1 pulley release. So CPT, trigger finger. this under there is trigger finger repair. Now, if you would have gone in a different route and gone to release in your CPT book, it's not going to get you to the actual code, but it's going to get you to the code series. Go to release and then tendon. Right under there, bone contracture 26508, which is not the correct code, but it'll take you to the right area to get there. Because if you look at 26508, you realize that's the incorrect one. But looking up and down, you'll see it with the 80. That's always how I've done things, but I'm trying to think of other ways. A1 tendon. Alright, so they got the modifier there to indicate that it's right index finger, F6. And then your injection into your shoulder. Can you go to injection joint or, see this is a great instance where you can go to bursitis in your CPT book and it's not going to, or it shouldn't, I'm going to be surprised if it does. No, if you go to bursitis in your CPT book, it's not going to take you nowhere. That's why it's important to not just rely on that diagnosis. And if you go to bursa, it'll take you to injection, where it'll take you to the series, but then you have to determine, of course, whether it's a major or a small joint, which you would have to do anyway. But if you go to injection joint, it's going to get you to the right area. Or if you go to bursa, injection, it's going to take you to the right area. 20610. 20610 is the correct one. The only difference here in our answers is our modifiers. $76 is for back to the CPT book, will be in the beginning of the A manual.
For repeat procedure.
Right. So that would be correct.
We took the one from multiple.
Right. Remember when we were talking about our 51 versus our 59, the difference. And the 51 is just indicating that there was multiple procedures in the same OR setting that were different. They weren't the same. And of course, you got your LT for left.
What's F6?
The
Indicated
finger
finger. Okay.
modifier. Go to page 99 in your study guide. Got an operative note here. And I don't think there are very many operative notes in the test. There may be a handful of scenarios that you actually have to code for, but the majority of the tests is multiple choice, thank goodness. Operative note number 2 is indications. Patient has an excision of a painful cyst on the midline upper back. I would underline cyst, upper back. The lesion has previously ruptured and has significant scarring. Patient also has a painful cyst on the left upper back, so I'm going to underline left upper back. That already indicates to me that we're dealing with multiple cysts. The patient is allergic to PNC, PCM, penicillin, and takes aspirin and Mockardis for blood pressure. Informed consent was obtained from the patient. Risk of the procedure, including bleeding, infection, scarring, and recurrence, were explained, and the patient acknowledged understanding of these potential complications. So, based upon the indication for the procedure, we already know we're dealing with multiple cysts, and that's why we've got 2 procedure notes here. Says that the pre-op measurement of the lesion was 1.1 centimeters. So remember, with our lesions, that's how we code them based upon the measurement. But to include margins, all that good stuff, but always just underline all of that good stuff and determine which one's a good one and not later on. The proposed excision lines were drawn. Anesthesia was delivered locally with 5.0 cc of xylocaine with epinephrine above 110. The site was cleansed with betadine. The site was prepped and draped in the usual sterile fashion. An incision was performed with the number 15 blade extending deep through the dermis and into the subacute fat. This tissue was dissected from the patient with care to preserve solid histologic features. The cyst was not enucleated intact, but the contents of the cyst wall remnants were extracted. The specimen was placed in a bottle of formalin labeled with patient's identifying information. The specimen was sent for pathology and or margin analysis. The surgical site was undermined to a distance of 1.5 centimeters. Hemostasis was obtained by electric artery and vessels ligated as necessary. In order to prevent dehiscence due to wound tension, an intermediate layer closure was performed. Remember, our closures are all determined based upon their complexity, intermediate right there, so underline that. 3 4-0 vicral sutures were placed subacute utilizing a simple inverted interrupted stitch. 4 4-0 nylon sutures was placed cutaneously utilizing a simple interrupted stitch. The final length of the surgical repair was 2.5 centimeters circle valve. The surgical site was cleaned with saline and sterile dressing was applied utilizing the following: sterile petroleum, I don't know what that is, gauze and taped into place to form a pressure bandage. The patient tolerated the procedure well. Post-op instructions were given to the patient. Patient instructed to return in 9 days for suture removal. Because the cyst ruptured during the surgery, we will have to give him a course of Cipro, which cleared the secondary infection after the cyst ruptured several weeks ago. All right, so that's the one that was done on the upper back. It shows you right there, procedure 1, excision of cyst, midline upper back, and then procedure number 2, the excision of cyst, left upper back. Everything's the pre-op measurement of lesion 1.5. Underline that. Keep reading down until you get to in order to prevent dehiscence due to wound tension, an intermediate layered closure was performed. The final length of the surgical repair was 2.9 centimeters. That's good. So our procedures are the excisions of the cyst. So you can go to your CPT book and look at cyst, but I'm not going to take you there. I'm going to go to excision first.
Yeah. Studying a little bit, what's up with you? I'm not at home,
But
baby.
if you go to excision
I'm
and
not at home.
cyst, it doesn't
Yeah,
even,
so did you
those
call
are
him on
for
his
deeper
phone?
things. It doesn't even talk about the skin there.
No,
Excision.
no, he's up, go ahead and call him. Okay. All right, bye, love you too, bye-bye.
No. You have to go to excision and then to skin to get in the right code series. The reason why you're not gonna find it under cyst is because excision of cyst doesn't have its own specific code. Remember, our excision codes for the skin are determined based upon the pathology, whether benign or malignant. A cyst is just, it may not be a neoplasm, but it is benign excision. So if you go to excision and then skin, it's going to lead you to 11400 through 11471 series of benign skin excisions. Now, had you gone to cyst and then to skin, it's just going to take you to puncture aspiration. It's not going to take you to the excision codes. Okay, so 101 or 11, what did I say, 114? Yeah. So first we have to code the actual excision. Remember, it kind of gets complicated with your repairs and your excisions from your integumentary system because it's a two-part, it's like a layered process to get it all taken care of, your excision and then your repair. So first thing is your excision of that cyst, and it said that the pre-op measurement was 1.1. It doesn't say anything about margins, it doesn't say anything about a post-op measurement. The only measurements other than that one are the repairs or the underlining that was needed to be performed. So we're going to code that procedural 1, midline upper back to 1.1 centimeters. Yep. So 11402. And then on procedure 2, left upper back 1.5. Same thing.
Same thing.
Oh, wait, why was that now?
11402
Yeah, why? You don't go by the 2.5?
to 2.5.
That's the repair.
Okay.
Oh, gotcha. Never mind.
Okay. Now remember, and it tells you in that summary there of those codes that we're looking at, the excision codes, that these excisions include a simple repair, but not an intermediate. And remember when we were reading over both of these procedures, these included a layered closure. So then we have to code the repairs separately.
You did the 11402 and then you're gonna code the repair.
Right, for each one. So if you go to, in your.
So would it be 11402 times 2? Or would you code it twice?
Twice. Well, I don't know yet. Let's look at the repairs first.
Okay.
Remember our repairs, that they're the same anatomical location and the same complexity. In this case, they're both of the back, different areas of the back, and they're both intermediate.
You add them together.
So we're gonna add the 2.5, no, sorry.
Yeah.
The 2.5 and the 2.9 together to determine our repair code. If you could just get used to the integumentary systems chapter of the book, and as a basic learner, it's not really gonna be necessary to you at this point. But when you get out in the real world, you realize that an outpatient coder utilizes this integumentary chapter more than any of them, along with that E&M, especially emergency room. But if you need to go to your index and look, that's fine, but I just wanted to show you guys this. When we are reviewing everything, remember, you've got the format, biopsy, shaping, excision, repair. So if you just flip over a few pages, you'll always find the repair there. But if you can't remember that, go to repair in your index. I'm just trying to make things easier for y'all. if you can hold on to anything. Some of it just makes you more confused, I'm sorry. But if you go to repair on the index and then the skin, it tells you see also repair a laceration. And then if you go to repair a laceration, if everything is there, you see. But that's how I would have found it going through the index.
All right, this is the one that confused me when I did it. I knew it sounded too familiar. I got all screwed up on it, and I got all screwed up again. Because I don't understand.
If you go to repair,
No, that's
Oh.
what I understand. I can get all that. I don't
actually-
understand, we should add, okay, we should add the two repairs together and get a total. But when you go to the back and look at the answer, it doesn't make sense to me, the code that they're telling me to use. I don't think. Maybe I'm wrong, maybe I'm crazy. Okay, I know what I did wrong there. I was looking at the wrong part for the, I got that one. But in the back of the book, it says, on the 11402, you put a 51 on both of them. I don't understand that. Why would you put a 51?
Because they were multiple procedures, they weren't done on the same thing. That's the only way I can get that 51, that 59. Let me
I don't know why
back up.
you would put a modifier on both of them. I can understand why you put a modifier on one of them.
Well, the reason why is because the primary procedure in this case was a 12032 because the RVU is higher. I'll explain it in 1 second.
Okay.
Okay, so if you're at repair the index and you go to skin, laceration of skin, and then you go to back, intermediate, 12031 to 12037.
No, you've got the items which you have together.
So 12031 through 12037, now we're going to determine what the amount
One of them was 2.9.
of repair.
One was 2.9.
It's going to be 5.4.
When you add them together, you're gonna find.
See, that's
It would be
1203.
the 12032.
Yeah. Now, what Kathy was discussing was, if you look at the back of the book at the answers, they've got different modifiers and stuff, but I would really ask you guys not to look at the answers until you are completely finished with it. So code that spacious cyst out, or the skin cyst. It'll take you straight to an index. But remember, when you determine how to sequence your CPT codes, it's based upon the highest RVU.
Right.
So when you look at 12032 and 11402, you have to determine which one has the higher RVU. 11402, 12032. 11402 has an outpatient, I think it's outpatient. Yeah, non-facility is the stethoscope. 4.82 RVU is the red information.
Right.
12032, 8.95. So that's why 12032 would be sequenced first, and then the next
That's
two-
the repair.
Yes.
Yeah.
And then the next two would be sequenced secondly.
Right.
Coding
I got that.
rules say that they always want 51 modifier on multiple procedures. They always. It doesn't matter if it's second or third, unless it's an add-on procedure, they always want 51 modifier. Medicare will tell you otherwise.
Yeah.
For
Really?
testing purposes, I know.
I didn't know that.
Yeah, well, it depends on which ones it is, but I don't like to drill 51 of people's months for a
Right.
reason, because it cuts everything in
Right.
your
Yeah.
reimbursement.
Yeah.
But for testing purposes, multiple procedures get a 51 modifier, so your second and third, fourth, fifth, sixth will get a 51 modifier. The only time it would change to a 59 is if you did 2 procedures on the same lesion,
Okay.
you see?
Uh-huh.
51 is multiple procedures,
Right.
59 is
This-
when two or more procedures is being performed on the same lesion.
Right.
So read this out to us like the answer should be.
12032, 11402-51, and another 11402-51, and then the diagnosis code is 706.2.
So if we'd have removed 5 lesions, 5 cysts from the back, I would have put a 51. Oh, that just blows my mind, Jenna. I'm thinking money. I'm not going to get any money for this.
Well, that's why the doctors don't like to use it.
Yeah.
That's kind of a lot of times why they will actually,
So if it would have been 5 procedures, would we have put that 11402 5 times, would that be more? Or no?
if it would have been,
If
yeah,
it
if
had
it
been-
would have been the same measurements and everything
Oh,
of the
okay.
back, yeah. But if it would have been one that's smaller or larger, you have to go based upon that, but yeah.
Okay.
Now, this is a perfect scenario, and I remember telling y'all when I was trying to teach the excisions and repairs, this is where it kind of gets, but I forgot that I could add repairs together. That's, you know, it'll trip you up. Remember when you're reading over your summary of your code sets, though, it will, if you'll just make it a conscious decision to review your summaries of those, it will tell you to total length of several repairs in the same code category. 12031.
So how come the first one didn't get a 51 on it?
The 51's your primary. Your first one will never get a 51 or 59. Never, ever, 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 ever. That's the whole definition of modifier 51 and 59. 51 is indicate multiple procedures. 59 is indicate a procedure is separate and beyond that of the primary procedure. 51 and 59 will never be on primary. That just defeats the whole purpose. And 51 and 59 will never be on the add-on procedure. What's an add-on procedure? Those with the X and the crosses.
Plus.
Yeah. You got more questions, I can tell. You still don't get it, Christy, with that 51 and 59 on the primary?
Yeah, but I mean, are you getting paid if you just put it once? Without anything with it?
Are you gonna get paid for both of them if you just put it once?
Yeah, because remember, the 51 and 59 is to indicate that that second procedure is either something completely different than their first one or a multiple procedure in the same OR setting. There's a lot of confusion with those two. Just remember that for testing purposes right now, put a 51 modifier on everything but that first procedure, unless it's an add-on code, unless it has a modifier 59. It's either going to be 59 or 51 out. 59 is going to be one of those weird confusing situation, and I can't remember when I need it. Colonoscopies. They'll go in, they'll do biopsy with cold forceps, and then they'll go back and inject that same site with an ink. And those are two different codes, but it was all in the same lesion. So that's a 59 on that second one. You have to kind of, you have to ask yourself, what would you be thinking if you had this claim in front of you? Because you don't have the operating room, the procedure note. You don't have the nurse notes, you don't have the physician. All you've got is a piece of paper with 706.2 telling you a cyst. And let's just say you saw 11402 without modifier 51 twice and one repair code. The first thing that's going to come to my mind is, wait a minute, did you make a mistake and you reported both of these in error? You meant it one time? Because I only see that there's one diagnosis here. They don't know that there was 4 or 5 cysts. All they see is one diagnosis and they've got 2 procedures coded. So that 51 is telling them that you as a coder has checked and it's a multiple procedure and it wasn't put in incorrectly on the claim form. They're always looking for mistakes. They'll tell you made a mistake when you have. Now, you could do a 11402 times 2. The units times 2. I don't ever recommend doing units though. I like to itemize things out for simple reasons of, especially modifier 50, some insurance companies, if I just put one breast was removed and I put modifier 50 on there to indicate it was 2, not 1, they may not calculate it right. And they're gonna pay me for one boob when it was actually 2. So I like to do one side left, one side right. Or in this case, 11402, 11402. I wouldn't use 51 on the civilian side. It's totally different. I would have popped 59 on there.
Yeah, me too.
That's because of billing. We understand that. They're gonna pay half of that procedure with modifier 51. But correct coding, put 51. Never on the first, but always gonna be 51 or 59 on the second throughout procedures. Look at number. We need to just move left and then English. Oh, here's a good one, just so you, on page 81, number 10. These ones are too long. The separate reporting for use of mesh, code 49568, during a hernia repair can be reported for which code? Look it up.
It's only one.
You look it up in the book and it tells you it's an add-on code that you would list it separately in addition to code 4,
Incisional.
right? And it gives you the codes there.
So this just, for something like, just go to that first code they give you first.
You go to that one,
Yeah.
the add-on code, it'll tell you. In your,
If you look on page 80, number 8, when a service having both a technical and professional component, such as an X-ray is performed in the hospital, which modifier would be used by the physician?
I got confused on that one. The modifiers really screw my head up.
Yeah. It's a small section. It didn't need to at first. I didn't get it. I couldn't get it. But if you go to your, best way to do this is not freak out. Just go to your modifier section in the back of your book. Remember, y'all got a long speed for that test too. And the AMA book gonna be in front, unfortunately, but anyways, here, if you're not real sure, go straight to those choices to determine. 26, professional component. 47, anesthesia by surgeon. TC, technical component. AM,
physician team member service.
member of service. So, I mean, we're looking for the appropriate modifier to be used by a physician to capture the professional component. It's 26. Now you see us reading that and thinking, oh my, hell, I don't know what to do. But it's that simple. You see?
But what is the physician team member service?
Oh, I don't know. I don't use that AM. I've never used that AM ever. But a physician team member, I would assume, would be like they're doing a team, like the transplant services, or where there's actually a team of medical doctors that in order to give the patient whatever care it is. I've never utilized that. On the outpatient, you shouldn't. If you mind, I don't know. That all means everywhere.
Is it the CPT?
Number 4 on page 96. Christy texted me at 11:30. What's Mo's? Really? Really? And what was my answer?
In the study guide.
Look at the study
Look in the
guide.
study guide.
I couldn't find it in the damn
You
study
couldn't?
guide.
You really couldn't?
Flip thought, well, after you finally told me where to look, but I thought, well, where the hell is, I knew I'd seen it, but I couldn't remember exactly what it stood for or anything else. So what
Why
the
do you
hell?
Google it?
Well, I don't even think about that.
Christina knows at 11:30. Most surgery is to be performed on a 56-year-old with a basal cell carcinoma, and that right there is your keyword for that, BCC neck. If it helps to make notes on your test, you can make notes on your test. But BCC neck is great thing to be able to write down there. Gross tumor is completely excised, tissue divided into 2 tissue blocks. Remember when we were talking about Mohs, it's all determined based upon the tissue block and the sections. I think it is frozen section. If you're not real sure, it's on page
93.
93. I think you can.
You're welcome.
Right there, page 93. At each stage in blocks. So, we need to know how many tissue blocks. We have 2. So basal cell, this is the stuff I'm making myself. Basal cell, carcinoma, neck. I know we're having Mohs. We've got 2 tissue blocks. They're mapped and color coded at their margins. Frozen sections performed. A full thickness graft is used to harvest skin for the patient's left axilla. So we need to know that we've got a tissue graft, full thickness of the axilla or the armpit for 5 square centimeters. All right. So the first thing that we're going to do here is, I'm not sure. This is again this intake and area chapter is one I don't utilize index on very often because I'm so used to just going back and forth. So let's see if we look up Mohs. Enter index. Yes. Mohs micrographic surgery. It gives you the code series there. Alright, and then when you get to your Mohs surgery codes, again, it's always good to read your summary explanations. It includes and excludes of each code series. It also tells you and excludes. You also code for the complex repair or the code also flaps or grafts. So keep that in mind when you're getting ready to code the rest of the repair. At this point, these codes only include the actual removal of the tumor and the excision of the tissue specimens, the mapping, color coding, microscopic examination, and histopathologic preparation, including routine stains. And then they are, like the rest of the intake and memory system, divided by the anatomical location and then by size, or in this case, tissue blocks. So again, we have Mohs of the neck. So we are going to be where?
17311. 17311.
Yep, that's right. Now, how many blocks? 2. And 7311 includes up to 5. So you can look at this one and show that C is the answer, but we're going to go ahead and keep coding this out. Remember, we had that full thickness graph. to cover that spot. It was taken from the armpit and now it's going to the neck. And I told you guys, don't ever forget about reading the summaries, and your exposed coat also flaps the breast. The breast section tells you there. There's no need to go to your index. It tells you right there. It starts at 15050. When you get to 15050, you'll see that all of your graphs, we scan through them fairly quickly when we're going through the chapter. But you've got several different categories. You've got a pinch graft, you've got skin graft and replacements, and then you've got skin substitute graft applications. Remember, this section has been thoroughly revised and codes deleted and added on this year to try to make things a little bit more simplified. But anywho, we're going to be at the skin grafts and replacements. We're talking about 5 square centimeters of the axilla. So again, these are divided by anatomical region. You've got 15100 is split thickness. We're not looking for split thickness, we're looking for full thickness. You got epidermal autograft on 15100. Just kind of have to keep going when you go like this. Now, I'm sure if you go on the index and graph skin full thickness, it would take you straight to it. But you got your split thickness, dermal autograft, tissue cultured skin autograft, tissue skin autograft. We're looking for full thickness graft. It starts at 15200. Now that's for direct closure donor side of the trunk, rid of the trunk. And then 15220 is your scalp, arms, and or legs. 15240, and that's another thing to keep in mind is you think your armpits are your arms, but always keep looking when it comes to anatomical regions, because 15240, you'll see that you've got your full thickness graft free, including direct closure of donor side, forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands, and or feet, 20 square centimeters or less. Now, why didn't they put a 51 letter?
Yeah.
Because they didn't code it correctly. I mean, they didn't code it all out. These, if you notice, they're just, they didn't even have icing on.
Right.
That's where there's confusion. People say, well, when do I put a 51, when do I don't? They didn't completely code that out. That's why they're trying to 51. If it would have been a code scenario, they're trying to 51. And then sometimes they don't. Let's see here. I can promise you your make it or break it will not be based upon a 51 to 59 modifier in that kind of case. The only time you're going to have a problem with 51 to 59 modifier is when it will distinctly just point out to you 59 is right for that rather than 50. Let's do the respiratory? We didn't do this. Let's get to that real quick, and then when we get to the respiratory and cardio, it's definitely going to open up a lot more for us. Okay, chapter 17, page 117, your respiratory. I didn't even bring, I don't know. The anatomy and medical terminology for the respiratory hemolymphatic section is all there, your ICD-9 coding to support it, this section. There's a lot of information here in regards to your asthma and COPD and the coding of bronchitis with COPD. It's good stuff to know, to be aware of. We've already gone over all that in our ICD-9, but they will test you on that specifically. So it's always good to be able to get to the correct codes and know that there's a difference in COPD and bronchitis versus 491.21. You'll see after you read everything. So the actual CPT coding part starts on page 122. We're talking last class. The main thing to remember with not just this system but other systems is that diagnostic endoscopies are all, if it turns into something surgical, it's always included. You never code out a diagnostic procedure along with the surgical procedure. There's a lot of emphasis put on that simply because there's been a lot of confusion in the past with coders who were not, when endoscopies were a new thing, and that's no longer the case. Nowadays, if they don't do it via a porthole, they're like, must have been bad, you know, but that's the way they like to do things nowadays, thank goodness. It goes through turbinate excisions, rhinectomies, kind of gives you a general background of the most commonly used procedures in these sections. Control of nosebleeds. These are, a nosebleed is epistaxis. That's one reason you won't find that control a nosebleed anywhere, but they're there, and it's just good, again, to review all that, your accessory sinuses. And just a review through this real quick, see if there's anything. On page 124, it starts getting into the laryngoscopy. Laryngoscopy, I can't even say it. You got indirect and direct. Those are the two differences in those two code series. It tells you that the indirect laryngoscopy involves the use of mirrors and lights to view the larynx, whereas the direct is an examination of the back throat and vocal cords using a laryngoscope. It's important to know what the difference is when that one piece of information is what's keeping you from the correct code selection. And just with any of the endoscopy codes, you're going to see the format's going to be the same throughout the book. You'll see usually the first one for that anatomical area will be usually a diagnostic, and then it'll index inward to include biopsy, to include excision, to include ligation of blood vessels, to include da-da-da-da. It'll be in that format most of the time. It tells you that it contains, that laryngoscopy category contains over a dozen codes and involves the most complex procedures. The most commonly performed direct laryngoscopies are those with the direct operative with biopsy, 31536 with operated microscope or telescope, 31541 direct operative with excision of tumor or stripping of vocal cords or epiglottis with operated microscope or telescope. It tells you that many of the endoscopy codes include use of a microscope or telescope. I think we went over that last time. 69028, which one was it? Where there's a microscope that, they'll probably have one question on the test. It's an operating microscope. We went over that, I know we did. It's a hot subject, and it has been for a long time, because again, new coders coming into it are like, well, why is that such a big deal? Why are you going on and on about it? Because the way the the way the basics of coding has changed so much over the years. And again, we've got all of these new and cool surgical procedures that we didn't have way back then. And back then, the microscope, the operating microscope, was not always utilized, but if they utilized it, it was a big deal. Now they utilize it all the damn time. I mean, if they don't use it, then they can't do the procedure. Our standards are changed, and it's a better way of patient care. So there's only certain procedures that will require the additional reporting of an operating microscope, and it's gonna keep on emphasizing that through every chapter. And this chapter is the same. There it is. Add-on code 69990 would not be coded because the operating microscope is included with that code. And there you go, reference to the guidelines. That is an inclusive component. You can find that in your CTI edits, that information that I sent you where you look it up and it shows you whether or not you can find it there as well. In bold on that page, 124, surgical bronchoscopy always includes diagnostic bronchoscopy when performed by the same surgeon. Keyword when performed by the same surgeon, of course. But this is the general rule across the board as we go on into the CPT book. On the next page, let me go back to those bullets on page 124. It shows you the code series 31622 through 31646 include fluoroscopy guidance when performed, that you do not report fluoroscopy separately when you're coding these procedures. And you're thinking, well, how the hell am I supposed to remember that every time? If you look at 31622 in your book, all of this information that's in this study guide is derived from the book. And it tells you for that code series, again, it's always good practice to go back and review the summaries of each code section. It shows you there that that code series includes the fluoroscopy guidance. The bronchial alveolar lavage 31624 is giving you general description of these procedures so that you'll understand them more. Lavage is sampling of the lung tissue by irrigating the saline followed by suctioning. And then and I don't know how to pronounce that, fiducial marker? I don't know. Delivered via the airway using bronchoscope, the code 31626 would be appropriate when physicians place that type of marker used to guide a thoracoscopy or to improve visualization for a lung ledge biopsy. It's giving you a little bit more information on the 31627. If you look at it in your book, 31627 is it's an add-on code. You see your little plus sign there. It tells you to add those on to most codes in that section for computer-assisted image-guided navigation. It includes 3D reconstruction. And then in bold, there in your study guide, CPT provides extensive parenthetical, did I say it right? Parenthetical notes throughout this section. And again, I think I said it 5 times already, and I'm sorry, y'all. But just like your ICD-9 never code straight from your index go to your tabular, the key thing to your CPT is always review those notes. All of your section notes, that's where your information, that's what tells you how to code it down, what not to do. Endotracheal ultrasound, EBUS. They throw things in here on your study guide so that you could get familiar with these abbreviations as well. Try to keep that in mind as you're reading. It goes on to tell you a little bit more about other procedures for the trachea and bronchi, and then lungs and pleura. Again, it gives you a general overview of all of the different types of procedures. And again, if you understand what you're reading or what it says, you're a lot more likely to get to the appropriate code. at the very last paragraph, code 32560 describes fluorodesis for recurring pneumothorax, a collapsed lung. The instilled agent tau causes adhesions of the surface of the lung to the inside surface of the chest. 32561 is for the initial day. 32562 is each subsequent day. Describes fibrinolysis to break up effusions. It's just, again, good stuff to be able to be able to understand before you actually start coding. I'm going to get straight to the coding highlights. Transplants are huge. I mean, they're huge in nature. The coding thereof is even bigger. You want to get it right. And it tells you on page 126. This is something that an outpatient coder never has to deal with. But you need to have, it kind of helps with the actual coding process itself and understanding that a lot of one procedure is not always identified with one code. And that's exactly the example for a lung transplant. You have to understand all of the actual steps that are needed to be done. And again, whether or not the same provider performed all of that work. We're going to keep on going, but just read up on that. A ventilator, you need to understand your ventilators. It tells you respiratory medicine codes. You're going to go off in a separate chapter when you get your respiratory therapy. Remember, right now we're dealing with surgical procedures. When you start getting your physical therapy, your rehab, you're in your physical medicine, which is the second, or your medicine chapter in the very back. Just the only thing that these chapters are covering are the surgical procedures that are performed by physicians. But it gives you a little bit of background on your ventilator there, and then the management for the ventilators, the codes to report them. It tells you where to go then. PFTs, and we'll go over all of this information a little bit more in that chapter, but it's just getting you ready to know that there's a whole hell of a lot more than just what this chapter has to talk about in your respiratory codes that you would think to find here. Mediastinum and diaphragm. General, let's see. They're all pretty straightforward. When you get to page 127, the very end, the Higgs-Pix level 2. Remember, there's Higgs-Pix levels associated with every chapter. Higgs-Pix is that little purple book that we were talking about. Your G codes. It tells you commercial payers may allow different codes, such as G codes or S codes. You will have to check the contracts. It's not something that we can just say, and tell you, because Medicare here in Mississippi may want you to report these. Medicare in California may not. You have to go through your different contractors to determine, but it gets you in the right direction to know that the G codes are available there. And I think that it may actually, in some of these where there may be a conflict between a Higgs-Pix and a CPT book code, that it will actually prompt you of that G code. It may not, but read up on that. And then you've got your modifiers and a glossary of the respiratory section as well. We're gonna do these. I say these are pretty straightforward. I don't think we're gonna have any problems with it. So let's do a few of these. Let's go to the big one in a minute. Let's see if we can warm it up. It's number 5. On page 130. A 45-year-old male with stage 3 non-Hodgkin's lymphoma showed pathologic cervical nodes on the PET scan. A biopsy was recommended. So right now we know we're doing a biopsy of our cervical nodes. A supraclavicular incision was made deep and down through the absent muscle. Ligation of the external jugular vein was performed and deep to this structure numerous large nodes approximately 3.5 centimeters in greatest height dimension were seen. Once elevated, the hillar aspect of one of the nodes was serially clipped with hemoclips to remove it. What code would accurately report this procedure? Well, again, our first thing is, what are we doing here? We're making a biopsy of our lymph nodes in the neck. But if you go to biopsy your blood, let's see if it'll take you there an easy way. Biopsy, and then I'm going to say lymph node. And when we get there, you have a generalized code series, but it further specified to include an injection procedure. That is not what it was. Laparoscopic, it wasn't. Needle, no. Open, yes. It wasn't a superficial thing. It tells you that the incision was made and it was deepened. So that's where we're going to go. So if you look at 38500 and the rest of them, you see you got biopsy or excision of lymph nodes, open, superficial. This is not superficial, it tells you deepened, deep tissues. And 38505 by needle, that's not right. 38510, open, deep cervical nodes. I'm going to make a little notation by that one. 38520, open, deep cervical nodes with excision of scaling fat pad, that wasn't done. And 38525, open, deep axillary nodes. I'm just going to go back to the book, and it says that ligation external jugular vein performed deep, large nodes, it's elevated hillar. I'm pretty good with the open, deep cervical nodes 38510. Deep.
That's right.
Is it? Everyone good with that one? Alright, let's go to the next one then, and then after this one we'll go to the hard one, but the format's pretty much the same throughout this chapter, or at least it is for me. It doesn't seem like there's really any big mountain to get over like it was with the skin and the incisions and repairs and all that stuff. Number 6, a patient with chronic maxillary sinusitis underwent a prior ethmoid surgery. A recent CT scan reveals mucous membrane thickening in the opaque sinus. An endoscope and scalpel are used to surgically remove diseased tissue, and an antrostomy is performed. What code accurately describes this procedure? Alright. There's, you can go removal, but go to sinus in your index. I'm gonna go blow my sinus out. Barely breathe. I've been doing good. Alright, so sinuses, and I'm just going back and forth on here. Remember, we have chronic maxillary sinuses. You have to keep in mind that when you're dealing with your sinuses, you don't want to 4. I think it's 4. Is it 4?
Yeah.
Okay, 4 sinuses. You've got your frontal, ethmoid, maxillary, and then it's
The one with the S,
sphenoid or whatever.
something like that, yeah.
So it's always good to just have a generalized understanding of that, because your sinus codes will always be divided based upon location. And so they will with your ICD-9s as well. But anywho, we're at our chronic maxillary sinus, and it says that antrostomy is performed. So if you go to maxillary, antrostomy is going to direct you at 31256 and 31267. You go to 31256 in your book. It shows you there that that code is for a nasal sinus endoscopy, surgical with maxillary antrostomies. That's exactly what was performed, so 31256. All right, let's look at page 131, the operative report number 9. I got to look over it. So our pre-op diagnosis and our post-op diagnosis is the same. They're both inferior turbinate hypertrophy, deviating nasal septum with nasal obstruction. The procedure, septoplasty with inferior turbinate reduction. Before we go any further, I'm going to show you what a lot of coders do. They will code based upon that. Because this is what a procedure note looks like, really. It'll have your pre-op, post-op procedure, and then it'll have the actual note. But a lot of coders who don't know what they're looking at will code based upon that right there. So let's code it based on that and see what it'll be. And it may be the same after, but 8 times out of 10 it's not. Septoplasty, if you look it up by septoplasty in the index,
What number are you on? 9. Okay.
it'll take you to 30520. And it tells you there that it excludes the turbinate reduction. This is a septoplasty with inferior turbinate reduction. Alright, so let's start from the very beginning. It says it's a 17-year-old young man who has come to me in the office with difficulty breathing due to his nose. He's been fine, breathing through his nose until about 3 years ago when he broke it. Since then, he has had a lot of problems with nasal obstruction. The physical exam did reveal a severely deviated nasal septum to the left, and this, coupled with inferior turbinate hypertrophy, is giving him 100% on the left side. It was my recommendation that he undergo a septoplasty with inferior turbinate reduction. Procedure's risks and benefits were discussed with him and his aunt in the office. They were agreeable to the surgery. All right, so again, a lot of this procedure description is protocol. Patient identified with pre-op. Maintaining which ones. Right side. It's just always good to confirm that what they say they did was actually performed. After the incisions were made, it tells you that a hemotransfixion incision was made in the anterior septum and muco, I can't pronounce that, flap was then raised on the left side. I came back to the bony cartilaginous junction and raised a flap on the right side. I removed the deviated portions of the bony septum, which were quite extensive, mainly to the left and then becoming more interior. He had a severe deflection of the left side of the cartilaginous septum. This was removed. He also had a very prominent maxillary crest on the left side, which I needed a hammer chisel to remove. After doing all this, the patient did have straightness with septum. So a foracomic was then sewn in a mattress-like fashion, back and forth across the septal flap to eventually close the hemotransfixion incision. It goes on about the elevator. The turbinate bipolar was used to reduce the size of the inferior turbinate's bilateral. That right there is your reduction mode. Had that not been there, a reduction would have been performed. And then everything's good. Chapter 7. This is what it says back here. Remember when I told y'all the turbinate bipolar was used to reduce the size of the inferior turbinates bilaterally? I told you that right there was your procedure note for the actual inferior turbinate reduction. The rest of that note was the septoplasty note, which is taken care of in code 30520. Now, again, if you look at 30520, you need to always do this when you get in these types of procedures, major procedures where you're dealing with major organ systems, because a lot of these bigger procedures include small procedures, but 30520 only excludes the resection. So if you go to, and the only thing it includes is contouring or replacement with graft. It doesn't include turbinate reduction. So if you go to reduction in your index, and then turbinate, let's see, you have to go to turbinate,
Nasal.
and you can go to turbinate mucosa and find it under ablation or reduction, turbinate, everybody knows it's the sinus.
Fractures.
They get to it, does it say?
There's fractional nasal turbinate OLS therapeutic.
That'll at least get you in the right section. I would have gone, I would have seen the turbinate mucosa resection and gone there. But it'll get you in the generalized area. Go to 30, what is it to you go to?
30930.
Okay. Go there. then yeah, that's just the wrong code. That's for fracture of the turbinate. So then I start looking up, is what I do. Because if you go down, it's going into sinuses, not turbinate. You get into turbinate destruction. 30801, ablation soft tissue of inferior turbinates, unilateral or bilateral, any method. Intramural, submucosal. And remember where I said the turbinate bipolar was used to reduce the size of the inferior turbinates bilaterally. It was bipolar cautery. That's what that is.
That's it.
That was a pretty tricky one. Now, if you look in the back of the book on this one, they applied modifier 59 to that second procedure because it's the same thing that they're working on.
Same thing, but a different procedure.
Right, it wasn't included in the main procedure. That was a tricky one. The key to determining when to add procedure codes and when not to, when you see it as one surgical procedure is being performed because you see one note. But remember, you can have 500 different procedures documented on one note. Only thing that one note tells you is that it was you were one OR setting, one setting. You were anesthesiazed, and then you can have 5 different procedures. You just have to make sure that when you're coding that you check your excludes and includes on those primary procedures to determine whether or not all of these other procedures, or sometimes it's obvious, just like the systems, But on these, when you looked at 30520, it did not state that it included the reduction of the turbinates. The only thing it said that it included was cartilage scoring, contouring, or placement of graft.
So that's one of the codes there?
The first is 30520.
Yeah.
And then the second one is the 30801, and then 30801 has modifier 59 to indicate that it's a separate and reportable procedure beyond that of the primary. Let's look at number 2, the number 10, page 132, offer report number 2. Recurrent right-sided epistaxis. And, again, a lot of these scenarios and questions are placed here because they think that you've already reviewed the chapter. So they expect y'all to understand a lot of this, so it may be, and it is. A lot of it's way up here when it should really be about right here for you because you should have already reviewed all of this. So don't be overwhelmed or let it intimidate you. Recurrent right-sided epistaxis. Remember epistaxis, what does that mean?
Nosebleed.
Nosebleed, that's what we call it. So this patient's got a recurrent right-sided nosebleed, and it tells you the procedure for right maxillary antrostomy with biopsy and right internal maxillary artery ligation. Again, we could probably code off of that procedure thing, but you need to make sure it's all been done. 71-year-old male with a problem with recurrent epistaxis. He did have a wildly deviated nasal septum, which I did repair about a month ago. But despite this, he's still having 1 to 2 nosebleeds a week that are fairly severe. Because of that, I did recommend to him to undergo an internal maxillary artery ligation. Procedures, risks, benefits were discussed. He agreed. Description of procedure. The patient was identified in the pre-op waiting area and taken back to the OR where he underwent anesthesia. Approximately 3 cc's of lidocaine with epinephrine was injected into the right inferior turbinate, the right middle turbinate, and the uncement or whatever process on the right. Afrin-soaked pledgets were then placed on that side of the nose and left there for about 5 minutes. These were then removed and a 0-degree nasal endoscope was placed into the right side of the nose. I used a Freer to medialize the middle turbinate, and then I was able to locate the maxillary ossea on the right side. I'm going to stop right there because I'm going to tell you what all of this just told me. The first few sentences told me that the patient consented and was placed under anesthesia. But that last few sentences tells me that, well, the last 3 or 4, the Afrin-soaked pledgets, those are the packings they put in the nose. I think they numb it up or whatever. It keeps the nasal from bleeding on it is that they removed it. And then they are using an endoscope. This is not an open procedure. It's very important to know that the 0 degree nasal endoscope is placed now. It may convert to an open procedure later. But these are the key words to hang on to, because that's what you need to know when you're looking for your code. It was on the right side of the nose, and then they use the Freer to medialize the middle turbinate and able to locate the maxillary ossea on the right side. So right now they're where they need to be with that scope. Following this posterior, I did end up using a through-cut forceps to widen the opening slightly to get me closer to the posterior wall of the maxillary sinus on the right side. Tissue was sent away for pathology. It did appear to be inflamed. I then used the Freer to raise the mucosal flap from the lateral wall. Once I was able to get to the posterior portion of the maxillary sinus, I was immediately able to see the right internal maxillary artery. I did isolate this both in front of, above, and below the artery itself. I was able to place 3 clips on the vessel. There appeared to be good hemostasis. The 0 degree nasal endoscope was removed. I did inspect the rest of the right side of the nose and the left side of the nose. It appeared to be a few prominent blood vessels, mainly on the lateral side of the nose, involving the inferior turbinate. I did cauterize these areas, giving them good hemostasis again. Just a small amount of blood suction from the nasopharynx. Alright, so they're saying that they did a right maxillary enterostomy with biopsy and a right internal maxillary arterial ligation. All of that supported that. Alright, so let's first code the enterostomy. That'll be pretty easy if you have enterostomy or sinus. We'll also, but enterostomy. And then sinus, and then maxillary, and it leads you to 31020 series. If you look at 31020, sinusotomy, maxillary enterotomy, that's enterostomy. And then back to the thing. If you go back, you can see that was the wrong thing. I went to enterotomy, not enterostomy. Enterostomy, sinus maxillary 31256. I'm sorry. Can you see how that one little thing? Alright. Nasal sinus endoscopy surgical with maxillary enterostomy. And then 31267 is with removal of tissue from the maxillary sinus. It excludes yeah, right, maxillary with biopsy. Three 1 2 6 7 would be for to include the biopsy. You double check. Chapter 7, 10.
That's right.
Yeah. So that 31267 is only going to include the ostomy and the biopsy that was performed. That would be, now you've got to code your ligation of that artery for your epistaxis. So you could go to ligation or you could go to epistaxis.
And you knew that
that was including the biopsy because it said removal of tissue?
Right. When it comes to, this is, I guess, a play on words as well. You know, when we're talking about our skin, and you're gonna see it throughout. I guess you're gonna see throughout the book that you've got different codes for excision versus biopsy. And a lot of circumstances, you will actually have for excision or biopsy. Look at the, I'm going to show you for example. What's our colonoscopy code? 6, no, 4, 4, 5, 4, 5, 3. 4, 5. 4, 5, 3, 7, 8.
Okay.
Look at 4, 5, 3, 7. These are your colonoscopy codes, and all I'm just trying to show you is that a lot of times the formats of the codes, they'll have the main procedure, whether it's a colonoscopy or an endoscopy of the sinuses, but the format will be the primary, as in 4, 5, 3, 7, 8, and you'll see if you look at 4, 5, 3, 8, 0, that's for with biopsy. But if you look at 4, 5, 3, 8, 4, 4, 5, 3, 8, 5, 4, 5, 3, 8, 3, all of those are for actually the excision or removal of. You see, you have different codes for excision versus biopsy in this type of procedure, and there's a lot of them throughout the book that do. However, for in your sinus, nasal sinus endoscopies with the enterostomy codes, you'll see you've only got 2 choices there. You've got one with the removal of tissue or one without. If it excluded a biopsy, it'd be under 31267, and nowhere under 31267 does it state that the removal of tissue from the maxillary sinus excludes that for biopsy. See? The only thing that's even remotely close is that for removal of a polyp. And it doesn't say this is a polyp. They're doing a biopsy. That's why it was acceptable to use 31267 rather than go looking for a biopsy code, because technically you got to remove tissue to perform a biopsy. But the way you're going to wrap your head around it to understand it is that the removal of tissue is usually a polyp or a lump or mass or lesion. But removal of tissue can make it a biopsy. Y'all get that? Removal of a mass wouldn't be a good one to code for biopsy of tissue. You get it? Okay, good. All right. So, our ligation, if we go to ligation, it should be there, or epistaxis. You'll see, if you go to epistaxis with nasal sinus endoscopy, it takes you to 31238. Don't look at me. Excuse me. Now got me. If you look at 31238, you would initially think that one's good. The sinus endoscopy surgical with control of nasal hemorrhage. You go up to excludes. It doesn't say anything about it. Let me go back and read that.
This is unilateral. You did a
Right.
bilateral. You did something on one and one on the other, right? I mean, does that make any difference to you? I guess not. No, I'm wrong. Never mind.
What was that?
Never mind, I'm wrong. He did everything on the right.
The operative note documents that the right internal maxillary artery was isolated and ligated, yeah. It says it's indexed under ligation artery maxillary.
It's
See, I went to
30920.
ligation, to maxillary, and it took me straight to 30920.
See, I went to ligation artery maxillary.
That's where and it didn't even take me to,
Yeah, it didn't take me that long.
yeah.
That's good.
And it didn't,
Excuse me.
it didn't
I
take me anywhere.
bypassed artery altogether.
Yeah.
Well, no, what I did was I went to epistaxis, remember?
Yeah.
With nasal sinus endoscopy and then control. It's got control right there, but I went with endoscopy. And you went to ligation,
Went to ligation, artery, maxillary.
which
That's
is
how I did it.
exactly, well, I don't ever like to go by the diagnosis, but sometimes you just don't know where to start. I would have gotten this one. Ligation, artery, maxillary. Now, if you would go to ligation, yeah. Did everybody else get that other than me? That's all that matters.
You've been sick.
As long as you're getting it, we're good. That's pretty straightforward.
And the book says put a 51 modifier. The answer in the back says put a 51 on the 30920.
Well, because there's multiple, and they're not inclusive to one another. That's why, but again, would put it.
I would have too. That's why I did.
There's a difference though, that's why I hate talking about those two modifiers. And so another reason why I sent y'all the CCI is, if you don't understand why we're having such a ferocious problem with it, is because there's a long history behind it, and coders can find a non-fraudulent way of getting things paid. But they wish you would put 51. Like the providers, and I don't agree with that. I don't think it's fair whatsoever.
Well, since it's all on the nose, that's why I would have put the 59.
Right, me too.
And it was all on the same side.
Right. But a lot of the insurance companies also, well, they've got these, they're called clearing houses. And you push your claim through.
Right, and they'll edit it out.
Yeah. And as long as it's got a certain modifier, I don't even look at it twice. And 59, you just slide on through. Whereas 51's gonna cut the payment in half right there.
Right.
If they catch it later on, it's a totally different story. What time is it? Because cardio is a bitch. There's no way to get around it. I hate cardio. So let's take a break real quick if y'all want one. Because these right here, you'll see the study guide itself is about half cardio. There's a lot to keep in mind with the cardio.
And see, I did interventional cardiology over 15 years ago. have not touched it since. Went straight back to the chapter, took the test and made 100.
Then you
That's
go,
how quick it came back.
well, then you need to get the interventional, they've got the specialty.
Yeah, I saw
exam.
that. I saw that.
I can get you a job. 15 years.
It's been 15 years since I coded interventional cardiology.
And do you like it?
I mean, I coded it for 4 or 5 years.
And do you do peripherals too?
Oh, I didn't do a lot of those.
Yeah, I don't
Yeah.
mind the cardiac cath, but peripherals is good.
Yeah, see, I didn't do a lot of that. I did the interventional. And
But if you like it, there's a lot of people who do not.
oh,
It's one of those where usually people with that specialty exam
Uh-huh.
and the there's another one. The ENM's a good one too. Got that one there. What's the other one? Looks OB or something. Anywho, it's a really good one to have because a lot of people are looking for coders with that
Really?
skill set because they're hard to find.
Well, that's good because I breezed right through that. 'Cause I saw how big that was. I said, crap, I'm reading all that. Let me just see.
Yeah. You all get a break? Yeah, okay.